Lovely. And you can all see that still?
Yeah. Yes.
Great.
Yes.
Good. Okay, so good morning, everyone. Welcome for the first session of the day. So I'll be covering some of the common infections in pregnancy. Please do stop me at any point if you've got any questions or if something isn't particularly clear. So in terms of what we're going to cover, we'll talk about some of the most common bacterial, viral, parasitic, infections. And if we've got time, we'll try and cover some of the STIs in pregnancy. And so the common ones, GBS, listeria, CMV, the torch ones, basically, chickenpox, toxoplasma. And we're going to look at how to diagnose and manage these infections, but also look at what the implications are for mum and for baby and for the newborn. Now, there are so many infections, it's just impossible to cover all of those in just one single setting. So there will be a lot of stuff that you're going to have to cover elsewhere. But fortunately, there are guidelines for most of these other infections. Sepsis, we've kind of spoken about before, but there is college green top guidelines on that. And I've got links at the end of the talk for all the relevant guidelines as well, but also for syphilis, HIV, hepatitis, malaria, and COVID. I think there's nothing new really to say for COVID, and it's always chopping and changing. And influenza, hopefully, we're all quite familiar with anyway. But that's what we're not going to cover this morning. So when we look at infections in pregnancy, what's really, they always talk about prevention is better than cure, which is definitely true with a lot of these infections. So can we think of which vaccinations are recommended prior to becoming pregnant to reduce risk in pregnancy?
Flu and obviously now COVID.
Yeah, perfect.
So the MMR prior to becoming pregnant, and
Yes.
with a gap between?
Yeah, do you know what the gap is?
I want to say between a month or two, but
yeah, no, usually it's a month. That's right. So normally they say not to get pregnant for a month afterwards. Anything else? I guess the other thing they say is if you've never had chickenpox, and you wanted to consider getting the varicella in vaccination, then yes, you can have that done. But again, I think avoid pregnancy probably about a month afterwards as well. So the seasonal flu vaccine, we've said, MMR, so chickenpox. Oh, and also not just vaccinations, but talking to patients about which foods they should avoid as well. Fine. What's our current antenatal screening for infections? What do we check for?
HIV, Hep B, and syphilis.
Yes, lovely. Anything else?
In young patients, would you screen for chlamydia, gonorrhea?
In which patients, Ebs?
I think under 25 years of age.
So it is recommended, yes, but whether it's not routine screening, but it's more of an opportunistic screening, but it's not part of the routine one. What I was just making sure is that we used to do rubella, but obviously we stopped that quite a few years ago because the incidence of rubella is so low because of the MMR cover. So yes, it's just those three. And then obviously if somebody is HIV positive, you would also test for hepatitis C as well. Okay. This is just a summary slide of the differences between live vaccines, killed vaccines, and the type of which vaccinations maybe you can give in pregnancy, you can't give in pregnancy as well. There's a link to this paper at the end as well. Some of this, the only reason I've put this up is sometimes this is quite an easy question for your part 1 exam as well. So for those of you who haven't sat it yet, and they do like to ask about different vaccinations, what's live, what's not, what can be given in pregnancy and what can't be given in pregnancy as well. Okay, so we'll start with, we'll look at bacterial infections first. So just some basic questions, just to kind of see how much you know already. So just shout out the answer. I mean, make a note of this yourself anyway, then we'll come back to this at the end of this section. But if looking at Group B strep, if someone's diagnosed with it antenatally, treatment with penicillin is not recommended. Is that true or false?
True.
Yeah, no, that's right. So if you were to find someone with GBS on a vaginal swab, so that yes, they wouldn't need to have that treated, but obviously it would have implications for labour and delivery. Listeriosis is associated with miscarriage and preterm labour.
True.
Yep. Routine screening of GBS is currently recommended for all pregnant women in the UK.
False.
Yeah, false. Generally speaking, whenever there's a question with all, it's generally false. The most common food source for listeriosis, so catching that listeria, is egg, poultry, shellfish, or soft cheese.
Cheese.
Cheese, yeah, I already gave it away in the first slide. And then GBS is a commensal in how many people is it a normal? Then it's normal bug for them.
Is it 20 to 40?
Yes, it is. Yeah. So it's just an important number to know. Okay, great. So GBS, it's a really nasty bug actually, and it's the most commonest cause of early onset, so less than 7 days of age, infection in newborn babies, and they can cause babies to be really sick. So they can become septic, suffer from pneumonia, meningitis, and 1 in 14, even if they were to recover from being sick at birth, 1 in 14 will end up with long-term disability, and unfortunately 1 in 19 will die as a result of GBS. So to me, that's quite high numbers really. So it's something that we need to be familiar with and be able to treat well to try and reduce the risk of babies becoming infected at the time of delivery. GBS carriage can vary amongst racial groups, are higher in Black African patients, lower in South Asian patients. What do we know about GBS? Where do we find it? So I said it's normal for some people. Where is it?
Vagina, but also rectum and urinary tract. You can have GBS UTI as well, isn't it?
You can indeed, yes, yeah. And we've already said about 20%. So it's actually in the lower digestive tract. So it's within the rectum. And then what happens is the bacteria intermittently colonize the genital tract and can sometimes go up towards the bladder as well. So that's why, and that would explain why some women, if they're found to be positive, may not necessarily be positive at the time of delivery, or some women will be negative at screening and then be found to be positive, or baby can still be infected with it because it intermittently colonizes the genital tract. So that's something important to know and helpful to explain to patients why. For example, if they've had a baby if they've previously had it diagnosed but baby was never affected, then that can kind of try to reassure them that they're at slightly less risk this time around if they're negative. So a few more numbers. Being pregnant, it doesn't necessarily affect your carriage of Group B strep. And this slide just shows basically if you're found to be positive at 35 to 37 weeks, 17 to up to a quarter of women will actually be negative at delivery. And if you screen some women, 5 to 7% will be positive at delivery. So that's why it doesn't make sense to, one, screen everyone late in pregnancy, because even if they're negative, they still could be positive at the time of delivery. And also babies are born before the screening gestation of around 35 to 37 weeks. So you wouldn't be able to catch all those babies. So for that reason, we don't screen. We don't do routine antenatal screening for all pregnant women. Whereas if you go across the pond in America, they do, lots of other high income countries, they do screen all of their patients. And obviously giving antibiotics to everyone just in case would do more harm than good, which is actually what we used to do up until a few years ago. Even if they had a previous GBS, then they would always automatically receive antibiotics in the subsequent pregnancies, but we've now stopped that, which is probably best practice. So who is at risk of getting GBS? What are the risk factors that you would be worried about? So
I
think of
guess
your patient.
previous GBS affected baby.
Yeah.
Prolonged rupture of membranes.
Yes. So prolonged rupture, if we just think about that, prolonged rupture at what gestation? So does it matter if I'm 34 weeks or if I'm 38 weeks? Or let's say 32 weeks and 38 weeks.
I guess if you're premature, your risk of having group B strep isn't necessarily greater, but if you have it, the risk to the infant is that much greater.
So actually, no, being preterm, you're higher risk of, I guess, yeah, you're at a higher risk of becoming significantly unwell with GBS. But also then, if you're preterm before 34 weeks, the risks of prematurity outweigh the potential risk of infection. So up until 34 weeks, you would generally, if somebody shroms with GBS, you will generally manage them conservatively unless there are signs of infection. Then after 34 weeks, the thought is that prematurity is not so much of an issue anymore. So therefore, you should always treat, but probably get on and deliver baby. And obviously, if you're 38 weeks, that means you're over 37 weeks, you're a term baby. So the usual rules apply of augmenting them straight at the moment of rupturing their membranes, as opposed to waiting for the normal 24 hours. So yes, so we've got prolonged SRUM, preterm baby, previously affected baby. So if we look at the ones EO GBS is early onset group B strep, so the likelihood of carriage in subsequent pregnancies is 50%, just so you can tell women. So you can try and give them an informed decision as to whether or not they want to have antibiotics. If their previous babies have been affected by group B strep, then they automatically get antibiotics in subsequent pregnancies, regardless if they're positive or negative. And then you can offer to screen women from 35 to, so 3 to 5 weeks before delivery, so 35 to 37 weeks if it's a singleton pregnancy, 32 to 34 weeks if it's a multiple pregnancy. And if they're found to be positive, you can then give them intrapartum prophylactic antibiotics. And then if they are, I think Joe mentioned, you can get GBS in the urine. That's the same as having GBS in the vaginal swab. So therefore, they would need to have treatment of prophylactic antibiotics as well. And then we've covered the other ones. And yes, someone with a pyrexia in labour, obviously one of the bugs could be GBS, but in that instance, you would give them broad spectrum antibiotics as opposed to just benzyl penicillin, which is what you would use for just GBS. So hopefully we're all familiar with the doses. So you give a 3-gram loading dose, then 1.5 grams every 4 hours until they deliver. Ideally, you should give the antibiotics 4 hours before rupturing and 4 hours before delivery, a minimum 2 hours, and even before doing an ARM, for example. Obviously, if someone comes in with a SROM, that's different. This is interesting. What in our unit we use clindamycin if they're allergic to penicillin. What happens in other units? Because I only read this yesterday, and this is from the Royal College Green Top guidelines that clindamycin is no longer recommended because of the current resistance rates. What does everyone else use in their unit? Anyone know?
They might have recently changed us to ticaplanin.
Oh, have they, Ebs? Okay.
So maybe
I think Oxford is still clindamycin.
Okay.
Uh,
So
Yeah, at Wexham it's ticaplanin as well.
is it? Fine. I mean, I guess partly it would depend on local sensitivities, but I guess there's something perhaps worth looking into. I think that's probably everything for GBS. Any questions at all? Fine. So then we'll move on to listeria. So as we've mentioned, soft cheese is one of the commonest reasons, commonest sources of listeria. It can be very difficult to diagnose because women will have very non-specific symptoms, so febrile gastroenteritis or flu-like symptoms. So just something to be aware of. So asking them what they've eaten, if they do present with any gastroenteritis. Diagnosis by taking blood cultures, and this talks about taking rectovaginal swabs and culturing that as well. You can do fetal amniocentesis if needed as well, and treatments with IV antibiotics. Usually, the patient herself is usually not particularly sick, but can become septic or suffer from meningitis as well. But it's more the fetal effects are more severe compared to a mum. So the increased risk of miscarriage, IUD, or preterm delivery, and that's just spontaneous premature birth, as opposed to us necessarily inducing labour. Congenital infection can be fatal. And early onset, so if it's within the first 2 days of delivery, the babies usually present with sepsis because of placental infection, and if they present later after 5 days, usually with meningitis, is because of vaginal colonization, so the baby's picked it up on its way out down the birth canal. So that's it for listeria. So this slide is just attempting to summarize. So group A strep, I think we have covered that before, so that's why I've not covered it now, but this just summarizes the potential implications of the diagnostic tests that you would do. Sorry, someone to say something? No. Okay. So viral infections. So a few more questions for you. Now, rubella, it largely affects young females in the UK, I should have said. Is that true or false?
It's not very common anymore. You mean of like the small subset who is more likely to be affected?
Who's more likely to be affected these days with rubella?
I'm going to say young females, maybe because they haven't had their MMR vaccine because of that scandal back in the day. I don't know.
Any other thoughts? It's actually young males because the MMR, yes, there has been a scare, but overall the MMR vaccination program has been a real success, and the rates are still very low. But it's younger men presenting with mumps, orchitis, so that one's false. The risk of primary rubella contracted between 16 and 20 weeks is substantial.
I think it's only about 10% if you get rubella, isn't it? I think that's false.
Okay, we'll find out more when we come on to it. 50% of pregnant women are susceptible to parvovirus B19 infection.
Yes, true.
Yes, that's true. Approximately 60% of people in developing countries show evidence of past infection with CMV. It's a 50-50 guess.
True.
Okay. CMV specific IgM antibodies may be present for over a year following acute infection.
True.
That is true, and therefore it does make it difficult when you're trying to diagnose someone with with CMV, and CMV always causes infections. Sorry, symptoms.
False.
False.
False, yes. So that's an always question. Vast majority is actually asymptomatic. Okay, so rubella. Rubella is very uncommon. It's rare in pregnancy. And this is where, again, one of those part one questions talking about when will baby be significantly affected, so in terms of gestation. So the highest risk is up until 16 weeks, when 90% of babies will be infected and develop congenital rubella syndrome. And we'll have a look at, there's a slide on that after this. And then the risk of congenital defects is about 20% between 12 and 16 weeks. Between 16 and 20 weeks, if baby's going to be affected, then it's normally just deafness and no risk after 20 weeks. So significant risk up until 16 weeks, less between 12 and 16, and deafness between 16 and 20 weeks. It's diagnosed on blood antibody testing to see if mom's negative or positive. So the incubation periods, again, this is just something that you guys will have to rope learn because popular questions again, but the incubation period, it is quite long. It's 2 to 3 weeks, and women can be infectious from 7 days before until 7 days after the onset of a rash. So they can be shedding the virus unknowingly. Unfortunately, there is no effective treatment if it is confirmed, and due to the nature of the congenital defects, termination of pregnancy can be considered, especially if there's confirmed infection within the first trimester. So this just summarizes, it's a very basic summary really of seeing if women try and diagnose someone with rubella. So we all know the difference between IgG and IgM, I hope. So IgG would show a past infection, IgM would suggest a more recent infection. So if IgG is detected, then yes, that means that the patient is has had it before or has been vaccinated. And if it's detected, if IgM is detected, no, then not no evidence of recent rubella infection. And on the other side, if IgG isn't detected, no. If IgM isn't detected, that it means the patient is susceptible to rubella. So in that case, you would have to send another sample in a month's time after the possible contact. And you're seeing if there's any seroconversion between the two samples. And then on the right side, if there's no IgG, but there is IgM, that would suggest that there has been a recent infection. Any questions about that? So this just summarizes that in a little bit more detail. So in the first trimester, this says 100%, but it's 90 to 100% that babies will be infected. Risk of miscarriages around 20%, between 13 and 16 weeks, 15-20% of retinopathy and deafness. After 16 weeks, risk of deafness. And as I said, after 20 weeks, there is no risk. So these are the signs that you might see in babies. So they talk about the congenital rubella syndrome, and the classic triad of signs are cataract, which you can see on the right-hand side, cardiac abnormalities, so patent ductus, a PDA, and a pulmonary stenosis as well, and deafness. So it's one of the common ones that can cause deafness. Then other signs you can find, so maybe on the smaller side, have microcephaly, mental retardation, enlarged liver and spleen. They can have odd rashes and things as well. So it's not a nice syndrome to have at all. And that's rubella. Any questions about rubella? So parvovirus, there is a lot of, it can be difficult to tell the difference between parvovirus and rubella sometimes. And the way parvovirus works, it's a small DNA virus, but it mainly targets rapidly dividing cells. So, for example, erythroid cell precursor, so it will target red cell production, hence why it causes fetal anemia. Transmission is through respiratory droplets, and there's usually outbreaks in the spring. And we've said already that 50% of women are immune, therefore 50% of women are susceptible in pregnancy. The incubation period is 5 to 7 days after exposure, and women are infectious 3 to 10 days after their exposure or until the rash appears. And symptoms will normally peak around day 9, and the rash may appear sometime after that. So they may not even realise that they've been infected because the rash can present quite late. Patients are usually asymptomatic, or they can present with erythema infectiosum. So that's the red cheeks. And they can have very mild flu-like symptoms of fever, malaise, and arthralgia as well. So again, it can be very difficult to diagnose because it's quite non-specific. So it's just something to be conscious of, especially if they've got younger children. So we've said it will target red cell precursors, the rapidly dividing cells, so therefore it can cause fetal anemia and can result in non-immune fetal hydrops and ascites, which can progress to cardiac failure and IUD in around less than 10% of babies. So the risk of hydrops is in fact quite low, it's 3%. If it's going to occur, usually occurs about 5 weeks after infection and can spontaneously resolve in around a third of cases. But it's obviously something that you don't want to take a risk on. So you do want to follow up these patients quite closely. And again, just as the rash can be quite late, the signs of hydrops can develop later on as well after the infection. So it's normally recommended to scan the patient every 1 to 2 weeks for 12 weeks after the previous infection, and you're actively looking for signs of fetal hydrops and ascites. And then if there is any sign, they would have to be referred to a tertiary centre, but the mainstay of treatment is intrauterine transfusion, and apparently it's very successful. And these babies can recover and survive pregnancy well. Therefore, parvovirus infection wouldn't be an indication for termination of pregnancy. So on the right-hand side, I mean, it's quite straightforward to see if, someone's been infected and there is ultrasound features of it, or there's a seroconversion on the bloods that would confirm parvovirus, send them to a regional fetal medicine unit. And if it's not clear or it's not definitely diagnosed, then just do regular scans every 1 to 2 weeks, looking for hydrops. And if there's no fetal abnormality at 30 weeks or later, then you can reassure the patient, and then there's no need for any further scans. Chickenpox, we're all definitely more familiar with. I mean, I don't know if I've ever come across a case of rubella. I have come across a couple of cases of parvovirus, but chickenpox is always something that's always about, especially when there are outbreaks and things. You'll get called by GP or someone, or when you're on call, saying that someone's been potentially exposed, hasn't got a clear history of chickenpox, and what do you do? So the good news is that 90% of the antenatal population have already been exposed to chickenpox and therefore are immune. Therefore, primary infection in the UK itself is uncommon. And again, thinking about it, I don't think I've ever come across anyone that's had a primary chickenpox infection. Unless obviously you've worked in a fetal medicine unit, sorry. So again, it's a DNA virus. Incubation period is 10 to 21 days, and patients are infections from 48 hours before the rash appears until all the vesicles have crusted over. So again, good to know the information in order to tell patients, because you don't want them to be going out and about, coming into clinics and things until all their lesions have completely crusted over. Otherwise, they are still very infectious. Obviously, we know in children it causes a relatively mild disease, but the older you are, especially as an adult, you're more likely to suffer with chickenpox. And 10% of women can develop a nasty pneumonia and also suffer from hepatitis and encephalitis and even die. Treatment is with oral acyclovir, but only if you can administer the acyclovir within 24 hours of the rash and the patient is more than 20 weeks. They advise caution before 20 weeks, just because there aren't the numbers there to say whether or not it's completely safe or not in pregnancy, but it would be a case-by-case basis less than 20 weeks. But beyond, if it's been longer than 24 hours, then there's probably not much benefit of giving the acyclovir. And then there's obviously the immunoglobulin, which is effective when given up to 10 days after contact, but not once the chickenpox itself has developed. So once they get the rash and the vesicles, then it's not very helpful to give the immunoglobulin. Again, it's quite a nasty virus. It can cause lots of problems with the baby. So primary infection before 20. So what happens is the baby will, it can get it at any gestation, but it's the babies who become infected before 20 weeks. And then there's no initial signs in the baby at that time, but then there's reactivation in utero thereafter. So the earlier you get it, then the longer there is for it to be reactivated. Therefore, more likely that baby's going to be affected by varicella, by fetal varicella syndrome. I mean, you can see yourself all the potential problems that it can cause. And given the significant congenital morbidity, then termination can be considered for these patients. Prenatal diagnosis, there are specific features that the fetal medicine doctors can look for on scans, such as microcephaly and hydrocephalus and soft tissue calcification. But there needs to be a time lag of at least 5 weeks after the initial infection, because if you scan them too soon, then some of you won't be able to see all the features on scan. So it can be a very anxious time for patients, but there's no point scanning sooner because it won't give you any further information. CMV. So this is very common. 60%, even up to 100%, may have had a previous infection, depending on where you are. Usually it's asymptomatic in 90% of cases, and as with the other viral, as with most of these viral illnesses, they cause very mild, non-specific flu-like illnesses. So it's just something to always be thinking about, which I have to be honest, when we see these women, at the moment, we just think flu or COVID, don't we? We don't routinely think of any other potential viruses, but it's just something to be conscious of. I guess you'd think about it more if you had a patient with a rash. But yeah, flu-like illness, it's very non-specific. So CMV is the commonest cause of congenital viral infection, affecting about 1% of newborn babies. The infection rate is about 2% in pregnancy, but it's got a high transmissibility at any trimester, with increasing transmission as the pregnancies are progressing. 10% will have CMV at birth, and even then, of those that may look normal at birth and babies aren't affected, 10 to 15% will then develop problems after birth, typically hearing loss around 2 years of age. So diagnosis, again, with mum, you can either look and see if they've got IgM antibodies, but as we said in the initial questions, IgM antibody can stay positive for up to a year after delivery, so it's not very helpful. The best thing is to try and compare the current sample to an old blood sample and see if there's been any seroconversion, and if not, then the idea would be to send another sample probably in another month to see if there's been seroconversion in the second sample. And again, there are ultrasound features, and you can do amniocentesis from baby to see if it's infected, but again, if you do it too soon, you may get a false negative. All these viral infections seem to cause similar problems, to be honest. You can get growth restriction, enlarged liver and spleen, microcephaly. So it's quite easy to remember all of those. And CMV can also cause hearing loss as well, as rubella can as well. And like I said, those born without obvious symptoms at birth can develop problems later on, especially with their hearing. So this is just a summary slide. So again, of the infections I've spoken about, the impact on pregnancy and the diagnostic tests that you would consider. So toxoplasmosis. This is not a nice virus at all. So it's not very common in pregnancy, even though 90% of women in the UK are susceptible, and it normally comes either from ingesting, gosh, I forget what they're called now. It's completely slipped my mind. But ingesting these cysts, or gosh, can anybody remember what it's called? It's got God, I can't remember what it's called now. But basically, dealing with cat litter or eating unwashed raw vegetables and salads, or undercooked meat or raw meat. So ingesting those, or dealing with cat litter, not washing your hands properly, and then ingesting those cysts. So that's how toxoplasmosis will take effect, and then it spreads in the mother's lymphatic system. So they do get this lymphadenopathy, which is one of the telltale signs, and then they can get non-specific malaise and fever as well. I mean, virtually all babies will be affected. Definitely if the mum is infected in early pregnancy, and then 10 to 80% if they're later in pregnancy. There's no real treatment, but spiromycin may reduce the risk of fetal infection, but not the severity. And for those reasons, termination can be considered. And again, as with the viral infections, similar problems with hydrocephaly, large liver, large spleen, but you can get brain tissue calcification, which is quite specific to toxoplasmosis, that you don't really tend to get with the other viral infections. But you can also get visual impairment, long-term visual impairment as well. So that's why it's really important. Education is really important for these patients. So making sure, you know, telling them which foods to avoid, telling them to wash their hands properly, trying not to deal with cat litter or wearing gloves, being really conscious of what they're doing to try and reduce their risk of exposure. You guys can have a look at that afterwards. So that's the end of this talk, and then we will have time to go over STIs in pregnancy. That's been a lot of me talking, and it's always something that's a bit unclear, and I think until you sit down and you have a look at it yourself, it does take time for everything to make sense. But any questions so far? Okay, so we're going to, can I just check you guys are still there?
Yeah, still here.
Yeah. Yeah.
Okay, good. So we've got, I think, about 5 SBA questions. So GP calls you for advice for a 25-year-old patient who's 14 weeks pregnant, who has a 1-day history of rash, red spots behind her ears, across her head, neck, trunk and legs. She's got painful swelling behind her ears and temperature of 38. GP thinks she may have rubella. What are we going to do? Well, which one of these is the most accurate statement?
The last option.
Everyone agree?
Yeah, I agree.
Okay, good. Oh dear, I've highlighted the answer here already. Anyway, primate comes into labour at 36 weeks, contracting 3 and 10. She's 6 centimetres dilated, but membranes are intact. She's known to be GBS positive, so I've already said this. Give her a 3-gram loading dose and then 1.5 grams every 4 hours whilst in labour. Next one, 20-year-old primate who's 32 weeks pregnant with a recurrent oh, sorry, I haven't gone through herpes yet, but we will go through this, but hopefully you guys are familiar with this already.
It
What
should
are
be
you going to say?
normal delivery because it's not a primary infection and it's not within 6 weeks of delivery.
So you've got 2 options there, a normal delivery or the last one, prophylactic acyclovir from 36 weeks and normal delivery.
Or she might not have herpes by 36 weeks because she's only 32 weeks.
Yeah. Anybody else? So what the general advice for herpes is, if it's a secondary recurrent or a secondary episode recurrence, then you're right, no indication for cesarean. There's no reason for not to have a vaginal delivery, but some women will be worried about the risk of recurrence at the time of delivery, and because it's unpredictable, you can offer to give them prophylactic acyclovir from 36 weeks to try and reduce the chances of a recurrence at the time of delivery. So it would be the last option. So you can offer that to patients, or some patients will ask for it regardless. Question 4, 35-year-old in a 3rd pregnancy who's 18 weeks pregnant. She's got 2 children aged 3 and 5, and there's been some slapped cheek disease loitering around. What do we think? How are we going to diagnose it?
Would you offer us some serology?
Yes, yeah. So you wanted to check out antibodies for parvovirus. Okay. Last question. We haven't covered this, but we've done this previously. 2 weeks postnatal after vaginal delivery, 5 days of offensive vaginal discharge, malaise, and she's pyrexial with the sore throat.
Last one.
Anyone else?
Group A strep? The last one?
It is the last one, group A strep. Now, No one's come up, no one's asked about torch screening. I know it's more specific for polyhydramnios, but it's always one of those things which seems to be associated with, because it's obviously the infection screen. But do you notice none of my slides really spoke, none of them mentioned polyhydramnios, so I thought I would just touch upon this very quickly. It's very confusing in the literature in terms of, so this is polyhydramnios, just polyhydramnios on its own. I don't know what is happening other units, but we've basically stopped doing torch screens unless there's significant polyhydramnios or there are other features on scan. But the literature is a very mixed picture. Some infections can be associated with polyhydramnios, but interestingly, a lot of them, so CMV, rubella toxo, can also be associated with oligohydramnios. So there is no real consensus about it, but generally speaking, if it's just isolated polyhydramnios, then torch screen isn't beneficial. Because again, I can't remember the last time we ever found any specific infection with someone who's got polyhydramnios. Fine, so those are all the links that I've said. So yeah, a lot of bedtime reading, I'm afraid. Now let me bring up. So we'll be able to go through the STIs in pregnancy. It's just a TOG article because I thought it was a bit boring just to copy and paste it into a presentation. So let me just bring it up.